My title as a specialty is, and you could call me a pathologist. The technical title in Canada is medical biochemist, but you get called other things elsewhere, chemical pathologist. I was mentored very heavily by the endocrinology group, the clinicians at St. Paul's when I was a resident, and that's how I got interested in endocrinology. And then my lab mentor, Dr. Frances Rosenberg, who lives on the island, taught me what she knew about the lab end of endocrinology. And over the years, we've built up an endocrine service at St. Paul's offering specialized in rare tests. And one of those tests, we do the testing for acromegaly, which is both interesting and rewarding because we get to help people get diagnosed. And I was just speaking in Ontario about a year ago, and in Ontario there's about 10 different labs doing the testing, and it makes it so that not everybody's using the same method, and it means that the results are all over the map. So they were quite envious of the fact that everything's centralized to one place, and we've actually had to fight to keep it that way. It's kind of political. There's a little war about do-gooding. Anyway, so I'll talk to you about how we do acromegaly testing and why it works and what we're looking for. You probably have puzzled about what the pituitary gland is, and you've gone and looked. This is a diagram of the pituitary gland that sits sort of right behind your eyes. The surgical approach is through your nose because it's back there sort of right in the middle of your head. And it has what we call an anterior part or a front part and a posterior part or a rear part. And it's driven by a part of your brain called the hypothalamus that sits anatomically above it. Oh, great, thank you. So anatomically, there we go.
It's the little button.
I'm going to move it to there we go. Anatomically, the hypothalamus sits above the pituitary gland and sends signals through neurons down into the pituitary gland to tell it to produce hormones. So the pituitary is the master of the master gland, and the hypothalamus is the master of the master gland, and the pituitary is the master gland, if you like. And we're going to be talking about the anterior pituitary, the front part of the pituitary gland. It makes the driving hormones for basically the whole endocrine system. So that would be the thyroid, the ovaries in women, the testicles in men, the adrenal glands, and did I miss anything? I don't think so. And so one of the hormones that it makes is growth hormone. And growth hormone is kind of like, it's strangely enough, there's not a master, and there's not a gland that growth hormone drives. It actually drives the liver to make a hormone that we measure actually. So this is This is from that that poor criminal who offered himself to be sliced a million ways. So this is the pituitary gland here, and the hypothalamus would sit just right above it, right there. So it's basically all part of the brain, and I think everybody's oriented to what they're looking at. So we won't talk about the other hormones that the pituitary makes, but we will talk about growth hormone. So growth hormone has direct and immediate metabolic effects, and it has long-term metabolic effects. The direct and immediate effects of growth hormone you see when you exercise. It raises your blood sugar. It increases the rate at which fat is turned back into free fatty acids, so it can be used to make energy, okay, or make NADH if you studied any biochemistry. So one of the ways you can make growth hormone go up is simply by exercising, and that's a healthy elevation in growth hormone. You can make growth hormone go up with your hypoglycemic. If you fast, your growth hormone go up. And if for some reason you become hypoglycemic, like if you're a diabetic and you're taking insulin, you took too much, your growth hormone will go up. And it will do two things to counterbalance your low blood sugar. It will directly increase the blood sugar through the conversion of stored sugar in the liver, and it will also mobilize your fat so that it can be used for energy. So those are the immediate effects of growth hormone. The long-term effects of growth hormone are why people abuse growth hormone. I'm sure you've seen there's a brisk market in abuse of growth hormone among athletes and among bodybuilders. And the WADA, the World Anti-Doping Agency, is quite tuned in to the fact that people use growth hormone. Unfortunately, growth hormone, because it's chemically identical to natural growth hormone, it's hard to detect. But at the level of the liver, growth hormone stimulates the production of another hormone, actually a simpler hormone in structure, shorter sequence, smaller weight, a hormone called insulin-like growth factor 1. The reason it's called insulin-like is because if you look at its structure, it's very similar to insulin. If you've learned about what amino acids are, it has a similar amino acid sequence to insulin. And some of the insulin-like growth factors can actually make you hypoglycemic, but IGF-1 is not one of them. It actually makes you hyperglycemic. It makes your blood sugar go up. It gives you diabetes. But IGF-2 can make you hypoglycemic, and it can, interestingly, create a syndrome that's a lot like acromegaly in that it changes your appearance, but it's associated with low blood sugar instead of high blood sugar. That's very rare. In any case, IGF-1 has two major effects. It increases protein synthesis and cell proliferation, which is why athletes are abusing growth hormone, and IGF-1 for that matter. And it has effects on the skeleton. Now, because your bones have fused, your bone growth plates have fused because you're all adults, you don't grow taller. It's too bad. The only thing it can do is make your head size grow, your hand size grow, and your feet grow, and I think you're all familiar with that effect. If you are a teenager or a child and you have a growth hormone producing tumor, and we do have some of those in BC who would have been diagnosed exactly the same way as you, biochemically speaking, then it makes you tall in addition to the effects you'd have on your head, hands, and feet. And that is called pituitary giantism. It's kind of an old-fashioned sounding name, but those are the people who end up being 7 feet tall if they go untreated. So normally acromegaly is diagnosed by the clinical presentation, but as you know, the clinical presentation can be slow and insidious, and so you might not get diagnosed for a long, long time on the basis of clinical symptoms alone, unless someone hadn't seen you for a long time and said, hey, wait a minute, something looks different about you, why, can we look at a picture? And I'm sure you're familiar with the classical clinical clues that a patient has growth hormone excess. Their skin gets thick, coarse, they develop skin tags, they can get pre-diabetes or outright diabetes. You get changes in their jaw shape which lead to their teeth not having a malocclusion, not closing properly, the teeth don't feel like they fit, or you can develop a space between your front teeth. Change in your hat size if you're a hat wearer, ring size and shoe size, so people will talk about having to have their wedding ring cut off because they've let that go, or having going from size 8 to size 10 over the course of 2 years. Night sweats is a common early feature. Headaches, of course, peripheral vision loss, basically just associated with the tumor. One other thing people can get is galactorrhea. They can develop breast milk coming out of their breasts, whether they're male or female, and that's usually because the tumor makes prolactin, also the hormone associated with lactation. So I'm going to talk to you about the lab part. I don't think I've ever met any of the patients I've helped diagnose with acromegaly, so this would be the first time. And if you've had your lab testing done in a period of time since 2003, I would have been involved in some way or other. I'm going to tell you what we measure, how we measure it, and how we interpret it, and why it's actually tricky. So I don't know that you've ever noticed, but when you go to the lab, there's actually kind of a rainbow of tube types that we can use, and they have different additives in them, basically to protect the thing that we're trying to measure, because some proteins just fall apart once they're outside the blood, or they fall apart if some of the red blood cells break and release stuff from inside the red blood cell, like insulin does that. So when we're doing hormone testing, we're usually using either a red top tube, has no additives in it at all, and when the blood goes in, it automatically clots. Blood tends to clot whenever it touches surfaces, particularly glass surfaces. So what they do is they embed little shards of glass on the inside of the tube there. They're microscopic, but they're embedded in some polymer there, and that induces clotting to occur. Then we also collect hormones in these what we call PST tubes, and when they've got a glob of gel at the bottom. And the reason they have that glob of gel is because when you spin the tube, the red blood cells go below the gel, and everything else that's in the blood, we call the serum, will sit above the gel. And that way it separates the cells from the water component of the plasma, or the serum, I should say. And that way the red blood cells don't leak their contents and contaminate the sample or destroy the things that you want to measure. And then very often we measure proteins in what we call an EDTA tube. That's the purple one. And it just contains something that gobbles up all the calcium in your blood and other, like zinc and magnesium. And a lot of enzymes rely on zinc and magnesium to function, which I hear exploited on the radio every Saturday when people are trying to sell you extra supplements. And so that prevents those enzymes from acting and protects the things that we want to measure. So when we're doing the testing for acromegaly, no matter which test we're using, and I'll describe the two we use most, the sample is collected. Basically, it can be collected at your local hospital, or you can go to a private laboratory. We prefer you to go to the hospital. I know that the waits are longer. The specimen is what we call centrifuged. In other words, it's put into a spinner, and it causes all the cells to go to the bottom of the sample, and the liquid component of the sample to come to the top, and that's what we call serum. So when we talk about serum, we're just talking about the liquid component after the specimen is clotted. We pour the specimen off, we pour that liquid off into another container, we barcode that, and we freeze that sample immediately, because IGF-1 and growth hormone are both subject to degradation if the sample is left on the counter or shelf or whatever. So we freeze those probably within 30 minutes of collection, usually. I would hope shorter. It's shipped frozen from all over British Columbia, no matter where it's collected. It comes to us on dry ice. If it comes melted, we say too bad, so sad, and we say, specimen unsuitable. Please recollect. And then we get occasional nasty phone calls about that, but that's just the way things are. We can't analyze if it doesn't arrive frozen. And we store it frozen. We only run IGF-1 and growth hormone a few times a week because it's not a test that necessarily needs an immediate turnaround the next day or the next hour, the way that, say, sodium would or something like that. So we take all the specimens, suppose on Monday, we thaw them all at once. And when you freeze and thaw serum or plasma, it tends to get little strands of clot that reappear. So we have to take, believe it or not, a wooden spatula and go like this in the specimen and collect up all the little bits of fibrin, because I'll be showing you, I think we'll be able to go upstairs, there's a probe that comes down into the specimen to slurp up a fixed amount, which would be something like 50 microliters. And if it slurps up a piece of clot, it jams, and then you have to clean it out, or you have to change it. So it's a big pain in the neck. So we have to make sure there's no clot in the specimen. And so that's what we call rimming the specimen, and then we analyze it. This is the instrument that we use to analyze insulin-like growth factor 1 for the province of BC. This is called the Immunodiagnostic Systems, ISIS. It's manufactured in Bolton in the UK. We used to use a different manufacturer, but they pulled their assay from the market because of quality assurance issues that had been reported to the FDA. So we had to very quickly actually switch last year. Some of you who are getting their IGF-1 monitored over time would have found out that they needed a new baseline measurement. It's because this other company that has been a thorn in my flesh had pulled their assay from the market because of some problems with it, believe it or not, that personal friends of mine found who work at the University of Utah, and they had reported that to the FDA. So you might think that we would measure growth hormone because growth hormone is the primary culprit in this disease, but actually we don't measure growth hormone because it's not practically the best way. And the reason it's not practically the best way is because growth hormone is produced in little pulses all day long. And we would have to monitor, we would have to make multiple collections over, say, a 12-hour period, measure them all, and look at the kind of like average height or the average amount of growth hormone in your plasma. And that's not practical. Although I'm sure that's the way that it was done early on. So we measure insulin like growth factor 1 because its concentration is way more constant. It's kind of like an average of your growth hormone all the time. And so IGF-1 is the best thing to measure, but actually it's technically more difficult. Now I'm going to explain to you how these assays work in principle. How they work in practice is a lot more complicated than how they work in principle. Does everybody know what an antibody is? An antibody is basically a protein your body makes that sticks to something bad. So for example, God forbid, we get Ebola, we will make antibodies to Ebola, right? Or what have you. You know, any disease that you've had, whether anything like a cold or the stomach flu, if you have recovered, you have manufactured antibodies against that, and that protein will stick to that pathogen, and then your body's white cells will see that there's kind of a marker stuck to it, and it will gobble it up inside the white cell. That's basically how the antibody-mediated response works, and that's how you get better from illnesses involving a virus or bacterial particle. The antibody is usually manufactured by your own body, by your white cells, against a protein on the surface of the enemy. Now, as it turns out, in about 1960, someone figured out, well, why don't we use this stickiness of antibodies as a way of measuring things? So we would have to get an antibody directed against, let's talk about growth hormone. We need an antibody directed against growth hormone. But you don't make antibodies against growth hormone, because if you did, you'd gobble up and ruin all your growth hormone. And you can actually, there are some disease states where antibodies against something within you cause the disease itself, like hypothyroidism. Low thyroid is caused by antibodies directed against your thyroid. But what we can do is take human growth hormone and we can inject it into a rabbit, into their skin. And the rabbit will say, that's not rabbit growth hormone, that's something else. I'll make antibodies against it, and the rabbit makes antibodies against it. We can drain blood from the rabbit's ear because they have big ear veins, and then we can purify out the antibody. So if we get 2 different antibodies against growth hormone, we're ready to make what we call a growth hormone ELISA assay, and this is how it would work. You take the purified, we're going to have 2 different antibodies, so this one and this one technically have a different structure, okay? So we take antibody A and we stick it to a plastic bead. Buy plastic beads that are chemically activated to stick to antibodies. So we take that, now we've created an antibody-coated bead, so I want you to imagine that there's a bead there. A plastic bead usually has a magnetic core. Then we put the patient's specimen in, and the antibody sticks to the growth hormone in the specimen. And if the antibody's good, it'll only stick to growth hormone. If it's bad, it'll stick to other things. But we want it to be good. We'll try and make it so it only sticks to growth hormone. Now we've got growth hormone, an antibody, and a plastic bead. The next thing we're going to do is add a second antibody directed against a different part of growth hormone. And in this particular diagram, they've added a third antibody, but that's not usually how things work in the modern era. Usually the second antibody has coupled to it something that can create light, chemically create light, photons, or color, one or the other. So now what you got here is a sandwich. We've got bead, antibody, growth hormone, antibody, and then something that can create color attached right on here. Now we apply a magnetic field and all the beads come to the bottom of the container. The container is aspirated and made empty. Some washing solution is added and removed and added and removed. And now all we've got is beads and sandwiches. Now we add a chemical that creates the light reaction and we'll just produce. That's how it's done. Now it sounds really fancy, but I didn't have to do it myself because IDS ISIS manufactured it for me. We have done these kinds of assays from scratch in this laboratory, but most of the time the production of those antibodies is prohibitively expensive, usually $50,000 an antibody to get those custom manufactured. Believe it or not, all the labs in Lower Mainland used to have rabbit farms to do this, and that is no more. So this is an ELISA type assay, and it allows us to measure both IGF-1 and growth hormone. We just need different sets of antibodies. In acromegaly, we rely primarily on the IGF-1, as mentioned, and it actually is a more difficult assay than growth hormone because IGF-1 it doesn't exist in the plasma all on its lonesome. It has a carrier protein, lots of proteins don't exist on their own. They have carrier proteins. Testosterone is not a protein, but it does have a carrier protein. So it's a good example. Testosterone doesn't float around on its own in your blood. It floats around on a carrier protein. So what is IGF-1? Well, all proteins are made of the building blocks amino acids, and there are 70 of them in IGF-1. So it's like 70 Lego bricks all stacked together. And it has 3 internal bonds, which I'll show you. It weighs 7,600 grams per mole, if that means anything to you, and it's produced by the liver. And IGF-1 is what creates all of the growth effects that you've experienced having acromegaly. So it was the real culprit. This is the structure of IGF-1 on the left, and you can see why it's considered insulin-like in just kind of a putative sense, because it forms a kind of squirrely ring in 3 internal bonds. But there's more to it than that. There's actually identical amino acid sequence in sections of the 2 molecules. Now, the problem, this diagram is going to confuse people, but I'll try anyway. The problem is this guy, IGF binding protein 3. You can actually use IGF binding protein 3 as a surrogate measure of IGF-1, but that's the carrier protein of IGF-1, so they're always stuck together. And if you imagine it, if you're trying to measure IGF-1 and the antibody can't find its way because it's housed inside the binding protein, it just bounces off the surface. That kind of makes sense. It's hiding inside, so the antibody can't see it, right? Just like when a virus is in a cell, it can't be seen from the outside. It can only be seen from the inside. So the first thing we need to do is get IGF binding protein 3, which is messing everything up, off of IGF-1. And the way that we do that is by acidifying the specimen down to it's kind of the acidity of lemon juice or vinegar, about pH 2 or pH 3 in this case. That will cause the proteins to change shape enough that they don't stick to each other anymore, and then we get them separate from one another. Then what we do is we add a competitive binding agent. What we do is add a whole bunch of IGF-2. And the IGF-2 also sticks to the IGF binding protein, and it gobbles up all the spots on the IGF binding protein. So now we've got it out of the way, and we've got just the IGF-1 floating around free in the tubes. That makes sense? There's just a vacuum cleaner effect. Now we can go ahead and do the straightforward ELISA that we talked about, and we also put the pH, we also take the pH back to normal, the acidity back to normal blood acidity, so that the antibodies will work, because antibodies don't like low pH either. They don't like acidity. Whoops, wrong direction. Now, this is to convey to you that it's really hard to get a normal range for IGF-1. And that's one of the things that's a big pain in the neck for this assay. IGF-1 changes its concentration a lot with age. Down here we have kitties, and what they've done is plotted IGF-1 concentration on the y-axis versus age on the x-axis. So if you were 20 years old, your normal range would be between, say, the 2 red dashed lines, and the average would be in the middle. So everybody who's 20 should have IGF-1 at about between these 2 age categories. So if you look carefully, you realize that the IGF-1 of a 20-year-old in a 60-year-old is not normal. IGF-1 in a 20-year-old is higher because there's just a little bit of growth left over, right? And this is kind of borne out in their muscle mass and et cetera, et cetera. And if you're a kid, if you're a teenager, when you're going through your growth spurt, your IGF-1 is way into the acromegalic range for an adult, but it's totally normal for a kid. Kids do, I'm looking at my son, he's 12, his feet are enormous, right? They just get bigger, and they're getting bigger disproportionately to his body. So that's fine as long as that doesn't go on for too long. So in teenagers, very high IGF-1 levels are a bad thing. And I don't know if people are familiar with the numbers they get back from their IGF-1 levels, but if you're under control and you're in the 40 to 60-year-old range, I would expect you to have levels of around 100. That would be typical if you're under control. If you're at the top end of control, you might be in the 200, 250, and if your disease is still going on, you might be a little bit above that. But this is not our normal range, but it was developed by a friend of mine who's now at the Cleveland Clinic. And you can see how many patients they've run. Now these are normals. So how do you get access to 1,500 normal volunteers for your assay? It's a lot of work. You got to screen them, you got to make sure they don't have any diseases, you got to make sure they don't have diabetes or anything else that could adjust their growth hormone levels, and then you got to get their consent, and then do the analysis, and then do the statistics. This is a multi-$1,000, this is probably a $30,000 undertaking to do this right. So that's why we're heavily reliant on companies. I'm sad about that, but we are. Most of our assays that we do here, most of the interesting assays we've developed in-house. But this one we could do this with an in-house assay, but the challenge would be getting a normal range. So when do we do a growth hormone test? Well, we do, occasionally doctors order growth hormone mistakenly to diagnose IGF-1, and I see a very high growth hormone, and then I phone and I say this isn't normal. And that's what happened 2 weeks ago to another lady who's just seen Dr. Johnson. But we use the growth hormone test to monitor the extent of surgical or medication control in acromegaly. So we usually do this after an oral glucose load, so you get the 75-gram yucky orange drink once a year, twice a year, whatever, in 2 years. I don't know how often you do it. How often do you do it? Once a year?
That was one of my questions. How long or how often should I be asking my endocrinologist or my family practitioner to undergo that test for me?
Well, I mean, I wouldn't be able to answer that question because I don't actually personally manage patients with growth hormone. I'm sure it's in the Canadian growth hormone acromegaly guideline. Those kinds of surveillance techniques are usually yearly. But if there's been absolutely no change in your growth, if your IGF-1 were totally normal, there would be no need to, and you weren't having symptoms. So it's probably playing by ear. I know, probably.
It's like average once a year. If you're controlled and it's maintained, then probably not.
Yeah.
I don't know the last one.
Oh, well, you're probably under good control.
In Ontario, just speaking from my experience, but initially after my surgery it was every 6 months. And that's kind of in the guidelines that were put out by my endocrinologist, who's kind of the expert in the disease.
Who's your endocrinologist?
Shirini's at.
Okay.
And then once you're stable
I know
for
him.
5 years, I'm sure you do. Yeah, I mean he's.
I pooched some of the slides from my talk to him to put in here.
I won't tell him that. No, I'm sure he'd be very, very honoured that he used them.
Interestingly enough, I was having my family doctor do my IGF-1 and my growth hormone, but then I found out my endocrinologist was not getting that information.
Oh, that's too bad.
Too bad.
Well, I mean, you know what? Just pursuant to that, myehealth.com now you would be able to see those kinds of results. Not every kind of test result goes into MyHealth because you don't want people finding out all on their lonesome that they've been diagnosed with cancer or something like that. But results like this do end up on MyHealth. So if you ever want to feel like you want to check your result, bring it to your doctor. I'm not sure that IGF-1 and growth hormone end up there, but I don't really see any reason why they wouldn't. They do, okay. So that's a great service.
Can I ask a question?
Sure thing.
So when you're usually getting your IGF-1 checked without the oral glucose load, should you be fasting or not, or does it matter?
You don't need to fast. It's basically constant all day. It's kind of an average of everything that's happened to your growth hormone level in the last few weeks. So, I mean, it might not be weeks. I'd have to look up how long it kind of maps backwards. But yeah, you don't need to fast for an IGF-1 level. I think some of the hospitals had fasting as a requirement. I think Life Labs had fasting as a requirement.
My endo said he preferred it, but it wasn't necessary. And sometimes the morning the lab is just too busy.
Yeah, it's not necessary.
Good.
You could have it. You could have it anytime you wanted to. Sometimes about 10% of the time. Oh, so just back to the growth hormone. If your level goes below 0.5 after the oral glucose load, that's considered to be relatively well controlled. It used to be 1. The threshold used to be 2, and then it was 1, and now it's 0.5. The reason is because the assays are getting better and better and more accurate, and they aren't reacting with anything else except growth hormone. And so when that occurs, the thresholds tend to drop. So the current threshold is 0.5 for the high sensitive and specific assays we run. Sometimes your surgery is too successful and it knocks out your growth hormone entirely, and you actually have a low growth hormone. And you may have experienced that you got low thyroid and low adrenal and low growth hormone. If your tumor was very big, there's a big chance that you're going to become what we call pan-hypopituitary, that all of your pituitary hormones are either partially or entirely broken. But fortunately, we can give them back to you. The growth hormone producing tumors tend to be large, so there's a distinct possibility of knocking out some of the other pituitary hormones when you have the surgery. And I mentioned the other things we measure. Well, we always measure prolactin. There's two reasons that growth hormone producing tumors could create an elevation in prolactin. One, when you compress that pituitary stalk, you actually cause prolactin to be produced at low levels. But growth hormone producing tumors also often make prolactin because embryologically they come from the same tissue. And that would account for why some folks with what we call somatotroph adenomas or growth hormone producing tumors will have noticed breast milk discharge even if they're male. So that's very distressing for men. Galactorrhea is the name of that. So you call it lactation if it's normal and with a baby, and you call it galactorrhea if it's not associated with the baby.
But can it come out green?
No, if it comes out green, I would think that it might be associated with an infection or with, sometimes some breast tumors can do that. So I wouldn't expect it to look green unless it had, cultured something in there. It would just look like white milky discharge. You can look up on Google Images for galactorrhea, and you can see what it would typically look like. We've talked about the other hormones that might be affected, adrenocorticotropin hormone and cortisol, which are actually life-threatening not to have. Excuse me. And so we always check those. We always check testosterone in men, estradiol and progesterone in women, and the stimulating hormones for those, and of course thyroid hormone, because hypothyroidism causes a lot of fatigue and is kind of crippling if you don't get that. Nothing is perfect. You can get false elevations of both growth hormone and IGF-1, so you can get incorrect diagnoses, and that occurs when, believe it or not, if somebody happens to, let's say, this is one of the ways, if you've had a rabbit farm or if you had rabbits as a kid and you develop antibodies against rabbit, then if those antibodies are floating around, you can connect this what we call the capture antibody and the signal antibody together without the IGF-1 or growth hormone sitting in the middle. And so you create this, what I call like an artificial sandwich or an incorrect sandwich. And that happens, with all the testing we do, we catch one of those, say, once every 2 months, not on these assays, but just in general on all the different assays we do. So you got to keep your eye out for when the results don't match the clinical picture. Nothing from the lab is perfect, and when you get a lab test that doesn't match what's going on clinically, you should always doubt the lab test because, nothing is perfect. And students and residents and doctors tend to believe that the assay is perfect. The other thing we have, occasionally you get sample mishandling, so you might get deterioration of the thing you're measuring. So this sample sat on the shelf. This was a big problem with the old vendor, was what we call lot-to-lot variation, because they manufacture these solutions for us and we get them, but they're doing it in big vats, and not every vat is the same, and you can get changes in the results you get just based on the manufacturing process, which is a bit maddening when you run a lab. So is this the future of IGF-1 testing? I think we're going to dash upstairs. I'm going to show you this instrument. This is what's called a mass spectrometer, and we have 2 of them upstairs. It's a great way of doing testing because it's all in-house manufactured reagents, and that way we don't have the problems with lot-to-lot variation. The challenge for us in doing an IGF-1 assay is not that hard. The challenge is the normal range. So we need a really good comparison with another big lab that had great normal range data that we could adopt, or we'd have to do our own normal range study. So the nice thing about these things, there's no commercial reagents, there's no reliance on the company. We have our own chemistry in-house, so we don't run into lot-to-lot problems, because if we had a bad lot, we just make it again. And companies don't like doing that. If they have a lot that's a little bit close to being outside of spec, they're like, yeah, well, you know, good enough, and cross their fingers, and they do that, actually. So it's a assay we can control, and we've been very successful in diagnosing other diseases with this mass spectrometer, Cushing syndrome and Conn syndrome, a disease that causes high blood pressure, and it's also used in thyroid disease, although not here. So what about the drugs? Do we measure the drugs? The drugs are very expensive, as you know, if anyone's on pegvisomant or sandostatin. The drugs are pricey, and so you know, one of the things when you're dealing with a pricey drug is should you measure it, and then you can lower or raise the dose appropriate to the levels that you get. Not right at the moment. We don't measure pegvisomant or sandostatin itself. We just measure the effect. So, you know, pegvisomant is a growth hormone receptor blocker. So it's acting like growth hormone, but it's not triggering growth hormone's actions. So it's sort of blocking growth hormone's way to the places that it's supposed to go. So you can't measure growth hormone in those people because it'll be high. It just gets, because it's getting pushed out of the way all the time, it just mounts its concentration higher and higher. So you only measure IGF-1 on people that are on Somavert. So if you've ever wondered why you can't do an oral glucose tolerance test if you're on Somavert, that would be why. And then sandostatin inhibits growth hormone production, so you can do either route for testing, but we don't measure the drugs themselves, although we could in theory. There's no compelling reason to clinically. And that's just reiterating what I just said. We just measure the biochemical effect. So I think we got just over 18 minutes until our next talk. Why don't we just dash upstairs? I'll take you into the lab. I'll show you the instruments that we work on, and you can have a quick tour.